Good afternoon again. So I'm going to show two cases. One of them, the second one, I showed a number of years ago, but most of you probably weren't there. And since it was a pancreas case, I thought it would fit in. And I'm also going to ask you your opinion before I tell you what the diagnosis is, just to see whether I'm just stupid or whether I'm incredibly stupid. So here we go. So this is a 55-year-old woman with generalized abdominal pain for approximately 6 weeks. And she had this CT examination. So I'll give you just a couple of moments to look at it. So these are the transaxial images. I have a couple of coronal images. And her laboratory values were normal. She had a normal white blood cell count, normal amylase, normal lipase. So, what do you think? Of the following, which is the most likely diagnosis? Does she have pancreatitis, pancreatic ductal adenocarcinoma, an intraductal papillary mucinous neoplasm, or metastatic disease of unknown primary? So we don't have an audience response system, so we'll do it the old-fashioned way. So if you can raise your hands, anybody think she has pancreatitis? Okay, how about ductal adenocarcinoma? Okay, few hands. How about an IPMN? Okay, looks like the majority. How about metastatic disease of some other primary? Okay, a few. So it looks like the majority of you think that this is an IPMN, and that's what I thought. Let me go back to the images. You know, when I looked at this, you know, she's got these big cystic spaces within her pancreas, and it looks like the wall is thickened. There may be some nodularity within it. And it looked to me like she had peritoneal metastases. She had some deposits here that looked to me like, so I thought this was an IPMN, a main duct IPMN gone bad, that with invasive carcinoma and metastatic disease. And that's what it looked like to me. And her labs were normal. Well, I showed it to one of my junior colleagues, and she said, I think this is pancreatitis. And she was right. So one thing is, if you go back and look carefully at the images, we can see the main pancreatic duct here. So the cystic spaces that I was looking at weren't really involving the duct. They were separate from the duct. And here's a companion case. So this is a patient, young patient with necrotizing pancreatitis. Here we've drained his walled-off necrosis. And notice that he has these nodular deposits in his peritoneum and retroperitoneum. And what we're looking at here is nodular fat necrosis. Patients with severe pancreatitis can get nodular fat necrosis within the peritoneum and within the retroperitoneum. And if we go back here, you know, that's what we're seeing here. This is all fat necrosis and a little fluid collection. And these are just intra and peripancreatic fluid collections related to pancreatitis. So I learned a lot from that case. And it worked out well for the patient. She didn't have a malignancy, but it was a little embarrassing. So the take-home points are that areas of intra-abdominal fat necrosis can simulate metastatic disease. I now know that I don't want to diagnose an IPMN if I can't distinctly define the pancreatic duct and show that it is dilated. So here's the second case. This is a 60-year-old man with von Hippel-Lindau disease. And he underwent a CT examination. He underwent a pancreas protocol because he had had a pancreatic mass identified on a prior study. So we did pre-contrast arterial phase and portal venous phase imaging, and the arrow is pointing out his mass. So again, what do you think is the most likely diagnosis? A neuroendocrine tumor, pancreatic adenocarcinoma, a serous cystadenoma, or a mucinous cystic neoplasm? Okay, so we'll do the hand thing again. How many think this is a neuroendocrine tumor? Okay, the majority. Very good. How about adenocarcinoma? Yeah, not really a good look for adenocarcinoma. How about serous cystadenoma? Very good. We've got one person who's going out on a limb here. How about mucinous cystic neoplasm? Okay. Well, you hit a home run. Very good. That's exactly right. This is a serous cystadenoma. And one of the things that has been in patients, now I gave you the history that this patient had von Hippel-Lindau disease. And patients with von Hippel-Lindau disease have an increased risk of developing not only neuroendocrine tumors, but serous cystadenomas. And there have been a number of studies that have shown that the serous cystadenomas that some patients with von Hippel-Lindau disease get can enhance avidly, because they're what are called solid cystadenomas. And if you look at them histologically, and I'm sorry that I don't have the histologic slide here, but if you look at them histologically, they've got very small cysts, but most are made up mostly of glandular tissue and fibrous tissue, and so they enhance avidly. Now, if you look carefully at this lesion, there are a couple of little cysts that we can identify within the lesion, and I think that might have been a tip-off, these little cystic areas. And then the other thing is, if we look at the pre-contrast image and put a region of interest over it, you probably can't read it, but it measures less than 20 Hounsfield units, so it's very low, low in attenuation pre-contrast. So the take-home points here are that serous cystadenomas can occasionally enhance avidly if they're composed mostly of glandular tissue and fibrous septa, and the cysts are very small. The clues might have been, as I said, these small cystic areas within the enhancing mast and the very low pre-contrast attenuation that was within the range of fluid. Actually, somehow I repeated that slide. But thank you very much.